Welcome to the Wild Physio podcast with your host, Andrew Wild. Now, today I have Justin Richardson on. Super excited for this podcast. He's currently the head of Sports Rehabilitation and Athletes Authority, which is a sports performance and rehabilitation facility based in Artarmon in Sydney. I went there last week and it's a phenomenal facility. Very, very impressed. He has previously held Pathways and Academy physiotherapy and rehabilitation coaching roles at both the Cronulla Sharks and South Sydney Rabbitohs Rugby League football clubs. He has a Bachelor of Physiotherapy from the University of Canberra, and he's currently completing a Masters of High Performance Sport at UTS. He's also an ASCA Level 2 Strength and Conditioning coach and holds the title of Associate Coach on the ASCA's Professional Coaching Accreditation Scheme. Welcome, Justin. Thanks for coming on.
Thanks for having me, Wildy. It's good to finally get this chat underway.
Yeah, seriously. We've been sort of chatting back and forth for, I don't know, probably 18 months. We've never actually met face to face, I think. Have we?
No, I don't think we have. It's sort of the way of the 21st century these days, particularly with Instagram, LinkedIn. Facebook's not really much of a thing anymore, but there's more and more communication between clinicians and coaches, but far less face-to-face meeting. And I guess COVID hasn't really made that situation much easier, but at least on the bright side of things, it's far easier to connect with people both locally and around the globe than it was 10, 15 years ago.
Yeah, for sure. And I remember us chatting at the sort of early COVID about a few things, and it sounded like you were going pretty well at that stage, but then Athletes Authority had to shut down for a period of time, I think. Is that right?
Yeah. So we were looking pretty good. And then obviously, I mean, like every business, right? Like we had our own struggles. I mean, at that point in time, the main arm of the business was more in the sort of athletic development space. The sports rehabilitation side of the business was still in its infancy. So we had to shut down. We kept going from a physiotherapy standpoint, but that was just sort of your classic one-on-one physiotherapy sessions. And the business did really sort of quieten up during that time, but it ended up being a blessing in disguise because we were able to spend 3 solid months really improving our systems for both sort of internally in terms of how we run things, what we wanted to get out of our programs, and then externally in terms of what we wanted to produce content-wise for the clinicians around us. And then I think it's set us up really well for when we reopened in June last year, because we've really gone from strength to strength. Like I still remember having conversations internally with the staff when we first reopened, because at that point in time, a lot of us we were on JobKeeper, like I guess a lot of people around Australia, and we were talking, well, what are things going to look like when this ends, and what do we have to do? We've obviously got to work really hard to make sure that we're all really set up well. And then to look where we're at now in a brand new facility, I don't think any of us could have thought that was possible. And since we reopened, everything's just sort of grown exponentially.
Yeah, for sure. And the facility, mate, is second to none. I went there last week, actually. Physios need physios, and I went and saw Alan at Athletes Authority. I've got a bit of a patella tendinopathy on my left side that's been pissing me off for a while. So I went and saw Alan and I was impressed. But the facility's massive. Like it's 2 stories, or 3 stories if you include the roof.
Yeah, the roof is a bit of a challenging one. It's almost like it's the rite of passage to be able to get in. There's a few cars haven't been able to make it up that ramp. But yeah, no, I mean, when I first saw it, like before we moved into it, it was just I think it was a warehouse filled with just storage crap. But what the boys have been able to turn it into, like when I first saw sort of the artist layout when we were back in Clegg Street in the old facility, I couldn't believe it. I was like, surely this isn't what it's going to look like. And then it's turned out pretty much almost spot on to what they were planning. And like sometimes I feel like at the moment I take it for granted, because I walk in there and you really sort of have to stop and appreciate the size of the facility and just everything around it and everything that we've got available to us, particularly in a place like Sydney. And given that we're a stone's throw from North Sydney and the city, space is really hard to come by. So I feel really blessed every day to have that facility. Obviously it was great that you were able to come in, and Alan is he's a very good physio. He's a great mentor of mine. I take a lot from him. He's our most senior physio at the clinic. So I learn lots off him every day. We all learn lots off each other, and I think that's probably, like, taking the facility aside, one of the things that I sort of unashamedly tell people is that I really, really think that the systems that we have in place are excellent for growth and development of each other. Obviously, we've got lots of experienced strength and conditioning coaches around us. We're starting to build our physio staff. We meet very often, and we're all just mates outside of work. Like, we all enjoy hanging out with each other and getting around each other. So it's never really an atmosphere where we feel like we're just walking into work and then leaving work to then get out and forget about the place. Like, we've all sort of bought into the vision.
Yeah, for sure. I did struggle up the ramp to get to the car park. For the listeners, the car park's all the way up the top on the 3rd floor, and you've got to go up this ramp. But as you go up the ramp, it's a bit of quite a tight bend, and I've got a long station wagon. I was a little concerned there for a while. I was like, it's quite steep and it's quite tight. I was like, shit, I might scrape my car here. But no, it's great that you've got parking as well, especially in that area, because the parking's not great.
Oh, for sure. It's terrible. Some people that can't get up the ramp end up parking in Bunnings because it's only down the road and it's got free parking. But I feel like the architect that designed that building was definitely in some kind of Beetle or something that definitely didn't have any sort of length or size to it, because it is, if you saw it, it's like this 45-degree or almost 60-degree angle on the first ramp. It's incredibly skinny. And then you get to the top thinking, oh yeah, I've made it up the ramp. And then you see a second one right next to it. And it's just this almost like 80-degree bend still at that height. So I wouldn't like to drive up it in a manual car, that's for sure.
Oh, no way. But it was fun. I kind of enjoyed it. I made it. I didn't scrape my car, so I was pretty impressed. Now, mate, you've been producing a lot of amazing content with ACL rehabilitation in the last 6 months, probably. And I've noticed that you've had a bit more of a focus on the ACL stuff. So that was one of the reasons why I wanted to get you on. And a couple of the topics that we wanted to discuss was surgery versus no surgery, your rehabilitation sort of principles. First thing, let's go into a controversial topic that's been coming up a little bit more and more recently is surgery versus no surgery when someone does rupture their ACL. What's your take on it? And have you looked into the current research that Tom Cross has been doing over at the Stadium Clinic?
Yeah, look, it's a really interesting topic, and in terms of the passion project of mine, which is ACL Rehab, like I tend to spend a lot of my time obviously dealing with my rehab list, but then also externally, I spend a lot of time with orthopedic surgeons that I work with closely, as well as other sports doctors such as Dr. Tom Cross and even other physios. So I've seen all of the arguments. Like, I talk with some of the more advocates of the non-surgical pathway, as well as obviously spending time in the orthopedic community. And I think what gets lost amongst the regular clinician is that you hear the broad scoping arguments of well, ACL surgery is not needed or ACL surgery is needed, and you end up just butting heads with each other and you forget about the person that lies in the middle, which is the individual. And when you talk to these people, let's start with the orthopedic community, right? You talk to some of the better orthopedic surgeons, and I'll name a couple that I work with: Dr. David Parker, Dr. Justin Rowe, and when you chat with them, they actually are quite happy with a non-surgical pathway in the right candidate of patient, and they will give that time for them. However, what they're not happy with is when they have a person that has an obviously unstable knee, they're in a high-risk group, depending on what level of sport and athlete that they are and what they want to get back to, getting probably in that context inappropriate advice from somebody that's probably seen you don't need ACL surgery, and then they've gone from having possibly an ACL rupture. Again, this is just going off the case, like a non-existing case study, but they might have an ACL rupture with no concomitant injuries, and then they end up having a secondary pivot shift injury, and they do lots of damage to the knee, lots of chondral damage, lots of meniscal damage. And then it's really hard for them to get the person back to the expectations that person wants to get back to. So I think what we need to consider is it really comes down to the person in front of us. What are their goals? Do they want to get back to sport really quickly? And yes, I know that there's evidence to suggest that an early ACL reconstruction isn't better than rehabilitation, than delayed ACL reconstruction. But for a person in front of you that wants to get back in 9 to 12 months, they may not have that time. So you've really got to be asking the questions of that person, going, okay, what do you want to get out of this? Are you unstable? I think an orthopedic opinion is definitely warranted in all situations. Like I do see some of these non-surgical advocates publicly posting that you don't need an MRI, you don't need an orthopedic consult. And I think that that's going way too down the path of ignoring a specialty that is highly involved in this area. Where the non-surgical pathway does have a role to play is, look, if you've got someone that's had multiple ACL ruptures and possibly has had multiple ACL reconstructions, you're possibly starting to get an insight as well. Their movement mechanics aren't fantastic. Perhaps genetically, they're not blessed, that they're suffering multiple injuries. So do we need to start having the conversation about modifying the lifestyle of this person? And are the goals of the ACL reconstructive surgery conducive to what we're trying to help them with long-term? Probably not. So that's probably one candidate. Another candidate that I find for the non-surgical pathway is somebody, do they have a stiff and quiet knee very quickly post-injury? And that's something that I'm hearing quite a bit from the orthopedic community, that if they feel a knee and it's quite stiff and it's quite quiet, then they can give them a chance to go through that non-surgical pathway. So I think that's another one. The other one is obviously somebody that's got a lot of pre-existing strength and neuromuscular control. Because again, one thing that I think people forget about is, despite the fact that you might think that, like I hear some people talking about the ACL is like the ATFL, which for starters is just absolute rubbish. Like, it is far more important than the ATFL in terms of the knee and the stability of the knee. But if you don't have that stabilizing structure in the knee, you need to work incredibly hard, even harder, to have your strength and neuromuscular control even better than somebody that does have that structure present. And what people seem to forget is they think that rehabilitation is a journey, 3 months, 6 months, 9 months, and then, I'm rehabilitated. It's like, no, once you've had these injuries, you need to be doing this forever. For whilst you're wanting to participate in sports that place demands on that structure, you need to keep yourself in tip-top shape forever. Okay. And something that, again, like my sort of take on it is, well, we talk about copers and non-copers. And the problem with this argument is that we only really know who a non-coper is in hindsight, because everybody's a coper until they're not. So, and I mean, my partner is a great example of it. She was somebody that when she was 15, she hurt her knee. It was misdiagnosed as a lateral collateral ligament injury. And she spent a year ACL deficient and didn't realize it, and had minor issues with her knee. And for all intensive purposes, for that 12 months, she was a coper. And then she ended up with a massive pivot shift injury, tore both meniscuses, and got grade 4 chondral fissuring of her lateral femoral condyle and lateral tibia plateau. So you go, well, she was doing fine for 12 months. Yes, of course, she was misdiagnosed, didn't go through the right management pathway early, but she still failed non-surgical rehab. So I think what we've got to consider is, okay, who is the person in front of me? What are their goals? What is their pre-existing strength? What is their knee looking like? And then we make that decision. And for a lot of people, I will recommend going through rehab first before going into possibly an orthopedic procedure, because at the end of the day, the surgeon's not going to want to touch them unless they've got good range of motion, unless their knee's quiet with no effusion, unless they've got good strength. Because if they don't have those, then they're going to come out of the surgery with a lot of swelling, a lot of pain, poor movement control, and you're going to be fighting an uphill battle anyway. So I don't think there's any downside in starting rehabilitation. And what I tell people is, you'll know in yourself, because you either won't be unstable or you will be unstable. And I ask them and I go, has your knee given way on you? And people will go, well, no, it feels like I haven't hurt my knee at all. And some people will go, yeah, I'll be walking in a straight line and my knee will just collapse underneath me. And you can pick it out easily from there. The one that doesn't notice it is probably going to be somebody that may benefit from a longer term approach of non-surgical rehab. Whereas the ones where the knee just keeps giving out on them, they absolutely do need to see an orthopedic surgeon.
Yeah, for
Long
sure.
answer, but
no, great, very thorough answer and a great answer. And I think the copers versus non-copers you've got to differentiate between the two. And it's quite difficult at times, as you said. You know, a lot of people think that they'd be able to cope with a non-surgical approach, but a lot of people will not be a candidate. And we've had Justin Rowe on the Hybrid Therapist podcast before, and he's talked about this, and he talks about the fact that a coper needs to have an objectively stable knee. It shouldn't be giving way. The HOP tests need to be greater than 80% of the non-affected side. And there's other, the self-reported global knee function rating as well needs to be greater than 60. And then the COS ADL-S needs to be greater than 80%. There are other things that you need to factor in there. And I think you hit the nail on the head. You need to get an orthopedic referral and a consult. And you also need to speak to someone like a sports doctor as well, because I feel like a lot of people miss that route as well throughout the rehab process. Is they just kind of skip the sports doc. I think that they're really, really great at what they do, and they bridge the gap often between the physio and the orthopedic surgeon. And Tom Cross is doing some great work at the moment with a braced non-operative ACL rehab protocol. And I actually spoke to him yesterday via email. I'm trying to get him on the podcast, but he can't speak about what he's doing at the moment until he finishes in 9 months. He said it'll probably go to publication in about 9 months, but I'm going to have a similar conversation than what I'm having with you right now with Justin Rowe and Tim Musgrove. So they're going to hopefully come on the podcast in about a month's time. But mate, really, really good answer. You got anything else to add? And for the listeners, do you want to go into any of the other non-operative options you do have, including what Tom's doing at the moment?
Yeah. First of all, Dr. Tom Cross is one of the nicest people that I've ever spoken to, and he presented to us at Athletes Authority not that long ago about his bracing protocol. I was sort of first introduced to it because there was a boy in the Gordon Rugby Colts program that had gone through it, and he had a tremendously amazing result out of it. And since then, we've sent some people to Tom, and have had some really fantastic preliminary results. And so I think what he's doing has the potential. I won't say what he's doing is amazing, because as the due diligence of the scientific method needs to take place, and he needs to go through the publication process and the limitations of his study. But I think it is great pioneering research, and he has fantastic intentions in mind. And I think he's really starting to refine his process in terms of who are the better candidates and who are the not so great candidates for it. Because sometimes, like what we'll do typically, if we get someone that's got an acute ACL rupture now, is we'll collaborate with Tom, get him to have a look at the scan and see if they are a good candidate, and then we'll present the option to the patient. Because again, this comes back to the context of, it's not just about the knee, it's about the person in general. It's got to fit into the life circumstances of the patient as well. Like somebody that I've just taken on board, she just ruptured her ACL, and she has a 2-year-old child at home. So she can't be in a brace for 3 months with a knee fixed in flexion, because she just won't be mobile enough. Now, yes, I know in terms of post-surgery, you're not exactly that mobile, but you do sort of get back to a little bit more mobility a little bit faster than the bracing procedure. But I think what Tom's doing is fantastic. I think in terms of looking at the tear, and again, consulting the orthopedic community. Tim Musgrove is another fantastic surgeon as well, and seeing, well, what is the possible chances that ACL might spontaneously heal? I know that we don't really have a great idea yet about who is going to possibly spontaneously heal and who isn't, but I think coming out of Dr. Cross's work is we can sort of start to get an idea who might be a candidate for that, and that would be obviously a really nice clean ACL rupture, fibers in good alignment, really close to each other. And something that I've just learned recently is a lot of the people that do end up going for surgery that do have some of these nicer, cleaner tears, the surgeons will actually preserve most of the ACL, and they'll put the graft through it, which was something that was just like, that was really eye-opening for me. And I think, again, as a principle, it just sort of opened my eyes to the fact that I think sometimes as physios, we disrespect that community enough a little bit, and we go, oh, well, it's just an ACL reconstructive surgery, when there's so many ins and outs and so many things that we don't know about it. So in terms of with the other approaches for sort of non-surgical pathway, look, for me, it's just making sure that we get the knee quiet, similar to what we would do post an ACL surgery, slowly build up their muscular strength and capacity, and then start to reintroduce more demanding tasks to the patient, starting in a controlled environment and then moving to a more chaotic environment, and then letting the patient know that, look, at any point in time here, like, we're moving the demands on your body higher and higher, and we may get through this, we may not get through this. And as long as they're comfortable with that, then that's fine. And I think as long as you drip feed it to them and you gradually progress their demands, so the ones that are doing well tend to stay doing well, as long as they don't have any big shocks coming to their body that they're not used to. As long as you give them time, because I'll still take someone through a non-surgical pathway. I'd still take someone through a good 6 months of rehab before letting them return to sport. And I mean, I'm sure we'll probably talk about this later on in the podcast, but in terms of the surgical ones, like, I mean, there's a lot of talk about how long should we wait before return to sport. And there are some studies out there about 9 months, post 9 months. But in terms of being able to get the person, like, yeah, sure, professional athletes that work every single day to get their bodies right, they're coming back in 6 to 7 months, because they're spending 8 hours a day physically conditioning their body. But like, 9 months seems like a long time, but it really isn't when kids get in the way, work gets in the way, you go away for holidays, you have a little setback. So you've got to take all these things into account throughout the whole process. And it's the same with the non-surgical pathway as well. The moment someone has 2 weeks off training, it just comes back to principles of detraining. You've got to then take them back, build them back up, and go through that process again. You can't rush. I feel like in the sort of traditional physio model, we get really rushed to get people out the door, which we should be spending more time with them.
Yeah, completely agree. And often that means that the clinic needs to charge more and spend more time with the client rather than just going half an hour blocks. 45 minutes is great. An hour is great. Often you need those longer duration consults to really get a great result with, especially with a ACL or non-operative ACL client. Back on the ACL healing as well. So it has been shown in some studies that it can heal. And we know that. And for the nerds out there, so the physio students and the new grads and stuff, just look at the Ihara paper from 1994, Fujimoto 2002, and Costa Paz 2012. Now, the thing you mentioned, though, is going forward, we need to differentiate between who's going to heal and who isn't. And as you said, the stuff that Tom's doing is a start about figuring out, who are the people that are going to do well with non-operative rehab. The other point that I'd like to make is the fact that Australia has a really, really high rate of ACL reconstructive surgery. I think it's 95% plus or 97% plus of people that do their ACLs actually get surgery. But in European countries, it's often around that 50% mark. So I think that we're a little bit scalpel happy here in Australia. And Justin even mentioned that in the hybrid therapist episode about, the 45-year-old mother that has a skiing injury. She does her ACL. She doesn't want to return back to any change of direction sport. She plays a little bit of casual tennis every now and then. Does she really need to go for the ACL surgery when she has an objectively stable knee and she's doing quite well? Maybe not. So that's why you need to have the team around you to make this judgment. And I had a 52-year-old ex-professional dancer that ruptured her ACL probably about a year and a half ago. And we said, look, it's probably not worth it because she's got a really stable knee. She saw Justin agreed, and we went the non-operative route, and she's back to doing exactly what she wants. So yeah, you definitely need the team around you for sure.
Yeah, and I mean, possibly something that we may need to be a little bit better at is preconditioning patients to appropriate expectations for what recovery post the surgical rehab is going to look like. Because I mean, what we see is what the professional sportsmen go through, because that's publicized in the media. We see it on the football club's Instagram pages. We see it on Fox Sports, the athletes going in the gym on the Alter G on their first run. And then like what I don't think is spoken about enough. And there was a nice study done by Kate Webster and Julian Feller, identifying the gaps between the expectations of return to sport going into an ACL reconstruction and what actually occurred. And I think they identified that about 88 or 84% of patients expected to return to sport at the 12-month mark. And of that 88 or 84, I can't remember which exactly percentage it was, only 24% of them actually returned to sport at 12 months. And I think what we don't do very well is clearly articulate to the patients the pain that they're going to be in, the fact that they will get synovitis in their knee throughout different points of the rehab. Now, ideally they don't, but look, again, at times when we're flying close to the sun and we're trying to progress them, there may be times when we do sort of annoy the knee a little bit as rehab professionals. And I'm sure the orthopedic surgeons don't like that, but they love the other stuff that we do. So it's a little bit of a trade-off. And then as long as we appropriately manage it after that, then that's totally fine. I don't think enough understand the commitment that they need to put into their rehab journey. I don't think enough understand the importance of the psychological side of things, how the injury itself isn't just a physical injury, it's a psychological injury. And that area needs to, in my opinion, in the perfect world, gets addressed professionally as well. It's not purely under the bracket of the physio to deal with the psychological trauma that goes on to the patient, particularly when, again, in most situations, we're not there with them for a lot of their rehab. Like a lot of it traditionally is done on their own. So we don't know if they're moving well. We don't know how they're traveling in the gym. We don't know how they're changing direction. We don't know what it's like when they're reintegrating back into sport. So I think we need to really, really, really carefully map this out with the patient, just so they know that it's not like that this surgery is just going to magically fix their knee. And I know that Justin talks about that at times, where the surgery itself isn't going to be the thing that gets them to return to sport. It is part of the process, but there are so many factors at play. And what I find is that the people that successfully go through their rehab are the ones that they maintain. It's not a sprint, it's a marathon. They maintain their consistency throughout the journey the whole time. And you can tend to see, like, some will be really, really eager in the first month or two post-op, and then they fall off the face of the earth. And then others will start horribly, and then they come home like a freight train. And both of them, they tend to have their own sort of issues. And it's the person that just quietly ticks along in the background and just ticks the boxes, and never misses a session, and is all like asking you questions along the way. They're the ones that do the best, that I find. But I think we need to be better at talking to patients beforehand about what they should expect from the procedure and what they need to buy into the journey, because we really need to be empowering these people to take control of their rehab, because at the end of the day, it's not us that fixes them. It's not the surgeon that fixes them. We help them fix themselves.
Yeah, completely agree. And they need to buy into a long process. And it's just not a 9 to 12 month process. It's a process that continues on from there. Imagine someone does their ACL at the age of 20 and they want to play until they're 34. Well, they're going to have to do the right things for the rest of their career and onwards after that. So I completely agree. And even just a lot of people miss the idea of they've got to fit things around their life as well. You know, if you had a 40-year-old mother of 3 that works full time, has the kids, she doesn't want to get back to change a direction sport, is she going to want to go through the 9 to 12 months of rehab after she's already probably rehabbed after the initial injury? Maybe not. So you've got to think about the person as a whole. I completely agree with that, mate. And by the way, back to that, what you mentioned in terms of people returning to sport, there was a systematic review, which you probably read in 2011. I had a look at the exact numbers. Arden et al. In 2011, there was 82% of people after the operation returned to sport. 63% got back to the pre-injury level, and only 44% returned back to competitive sport. So I think that the ACL reconstructive surgery is great. I think that we do a decent job early on in returning them back to activities of daily living, getting them back to running, getting back into the gym and that sort of stuff. But returning them back to pre-injury sport, I think we've still got a long way to go. And I think part of that puzzle is potentially using more non-operative measures for some people, but not all people. This leads me into this next question, mate. I think that physios in general do a really good job in the first 2 months of ACL rehab. But I think the thing that we don't do well, and that's not talking about you and I, because I feel like we do a pretty good job at the end stage stuff because of our background. But what needs to happen with physios going forward that is going to allow them to be better at end stage rehab? And we're talking from about, say, 3 to 4 months onwards, especially when they're getting closer to returning to training.
Yeah, it's a good question. And like I've spoken about this before on another podcast, I think one of two things either needs to happen. I think depending on the environment around the physio themselves, they need to sort of identify, well, do I have the facilities, the capability, the business systems to be able to take this person through myself? If you can answer that box wholeheartedly with your hand on your chest and go yes, then the responsibility is on you to educate yourself on the end stage rehab principles, which is your traditional S&C principles, and being able to coach an athlete through those stages from when they return to run, being able to identify, well, what does a return to running framework look like? How do we then reintegrate them back into team training? What does that look like? What's my testing battery look like at different stages of the rehab to move them into more physically demanding movements? And then what does my return to sport framework look like? Do they return to team training and start with skills drills, conditioning drills, and just physical capability drills? And then after a certain period of time, do we then move them into more skill-based drills that are still in a closed environment? Then do we move them into return to contact? What do our return to contact progressions look like? Again, depending on the sport. And then how do we then integrate them back into small-sided games? And then how do we go from small-sided games into full team training? How long do we leave them in full team training and then go back to sport? Now, that sounds like a lot, and you don't need to have the perfect system, because I don't think that there is a perfect system or a protocol around that. I don't like the word protocol, because it implies that you use the same thing for every person. But I think having a framework, and this is where I think that what we can use time to our advantage. And by that, what I mean is we talk about how historically there was time-based criteria for return to sport, and now we've gone to a criterion-based progression for return to sport. I think we can still use time as part of that, in terms of, okay, we give them X amount of weeks of skills drills, X amount of weeks of basic contact drills, X amount of weeks of small-sided games, X amount of weeks of full team training, and then going 1 quarter or 2, and then 2 quarters, or 1 half, and then 1.5 halves, or to slowly get them back to full demands. So I think we can do that, but you got to have that framework around you, and you got to understand that from the start, rather than just waiting for the person to come in and trying in a 30 to 40 minute appointment to gather all the information and then set up the plan out then. So you've probably got to spend some time building out these frameworks yourselves in your own time. And then if you don't have that capability, and part of that could just be you don't have a gym in your clinic. If you don't have a gym in your clinic, then that's probably almost wiped out straight away, because you're never going to see the person in the gym, which I think is a flag. If you're not near a park, or you can't go to a park, then you're never going to be able to take the person to do a field session. Then that's a flag in itself. So if you've got those things as barriers, then I think what you need to do is you need to start collaborating with the S&C field, and not just anyone in the S&C field, because the S&C field is very broad in itself, and some people wouldn't have a clue about how to rehab an ACL. So I think you've got to try to find somebody that can help you take that person to the end of that journey and work together. And you know what? Part of that might mean blocking off some time in your diary, taking a bit of a hit, and going and spending some time with them so you can learn. And then, yes, you're not the person that's fully guiding that person to the end, but you get a better understanding about what they're doing with the S&C, and then you can help to put a plan together. I think where we get lost is that the physios take them from that prehab and first day post-surgery to return to run, and then they just hand them over, and then the S&C takes them, and then they never talk to each other, but the physio's still doing testing, and then the S&C's writing the program, but the S&C might be writing the program not knowing that they're doing this testing with the physio, and the physio's finding these deficits, so then the deficits aren't being addressed, and then it's just sort of ends up being lost. And then suddenly we're getting 9 to 12 months down the track. The testing might look okay, but not fantastic. But the person's pestering the physio going, oh, I really want to get back to sport, really want to get back to sport. And then the physio goes, oh, all right, well, it's been 9 months, it's been 12 months. You're looking okay. I think you'll be all right. And then something happens down the track. And again, I know people that have done the worst rehab possible, and they've done no rehab, and they go back to sport and they're fine. And yeah. I know people that are fully diligent with their rehab, have the best teams around them, and they still re-rupture. But I don't think that we can base our frameworks around those outliers. I think we've got to work around the majority, which is, well, if we do a really good job with them and either have a system around us to take them from start to finish, or work within a team to take them from start to finish, then we'll get better outcomes with these people.
Yeah, for sure. And testing is very important. And as you said, protocols, I'm not huge on protocols, but I like having a system in place of testing, especially with ACLs. And, I use a 2-month test, a 3-month, 6-month, and 9-month, and I repeat those tests if they fail certain things. And then the 9-month test is not a return to sport, because a lot of people think that that's a return to sport test, but it's not. It's a return to training test. And then if they fail certain things in the 9-month test, they will need to work on certain things to then pass that test. And that test is a test that I typically do over sort of 2 or 3 sessions, because there's strength, there's questionnaires, there's plyometrics, there's running, change of direction, all that sort of stuff, agility. So I break it up, and I also do it fresh, and I also do it under fatigue. So a lot of my clients are like, I don't want to do that test again, but I'm like, no, you have to. I want you to do it under a bit of fatigue as well, to see whether you're coping with the fatigue. So it's important to have the systems in place. And look, it's taken me years to get that to the point where I'm happy with it. But mate, I completely agree that the rehab needs to be a lot more, I suppose. You got to use the S&C, you got to use physio, you got to integrate all of these different parts of the cogs. You got to get the cogs going together in the right direction. Otherwise, you kind of just imagine if you get exactly what you said, if you get some deficits with your physio strength testing, and then you don't tell the S&C that they've got these deficits. Well, they might be working on things they don't really need to be working on. So you need to have that team around you. But if you're a physio thinking that you can get someone all the way through rehab to the point where they're back on the park, and back at training, you need to do things like take them to the park for their rehab running. You need to like go out of your way to do these things, because you can't just do it at the clinic, especially if you don't have a gym. I completely agree with that, mate.
Like spot on, absolutely spot on. And yeah, I think like you sort of hit the nail on the head where like when you are developing these systems for assessments, you'll go through processes of refining it. There'll be times when you'll be doing things and you'll pick up trends and you'll go, well, like I'm doing this test, but am I really getting much out of it? And look, I mean, from a literature standpoint, there's actually not a whole lot of evidence to support testing.
Yes.
Anyway, really,
Exactly.
It's starting to go the other direction. But I think what it does give us, and again, you hit the nail on the head, is that we're not identifying through these testing battery that these people are safe to return to sport in the sort of full definition of the word safe. We're identifying, are they capable of returning to sport? Because by definition, sport in itself isn't safe. Regardless of whether you're playing AFL or you're a runner, you're always at risk of stepping out the door and something happening to your body. So and this is what I communicate with people, is that there is always going to be a risk with going back to sport. We understand that, and we go, right, where our job is risk minimization. And I know that if you can't hop, do 3 hops on one leg to a reasonable distance and to the distance of your contralateral limb, then it's probably a flag for you being able to land, change direction, sprint, push off in your sport.
Exactly.
If you have piss weak hamstring strength, then I'm probably thinking that you may not have the capacity to have braking power to protect your knee and also your hamstring. If you don't have any quad strength, then you don't have deceleration control, and that you may find yourself in a position which would increase your risk of injury. So these are all the things that we're sort of looking at when we're making these decisions. And again, when you spoke about when an athlete passes this test, it doesn't mean that that's never approached again. I've had people present really well at 6 months, and I use a process. Part of my process is using isokinetic dynamometry. We don't have it available to us at AA, but we've got a link with some places that do get it done for us. And I've had people present really well with good quads and really great quads and ham strength at 6 months. And then it's actually not as good at 9 months as it was at 6 months. And then they turn around to me and go, oh, but I passed that at 6 months. And they go, but this is just a capture of where you're at this point in time. I'm like, you may have done poorly today. You might be better next week. You could have slept poorly and done and not performed very well. Like highly unlikely that massive variables can occur in such a reliable and valid test like that. But what I do try to tell them is like, this is just where you're at this point in time. Just because even if you performed well at this 9 month mark, that doesn't mean that you're going to be really strong at 12 months, at 18 months, at 24 months. Because what happens if you just stop training and you just started eating McDonald's every day?
Exactly.
Like your physical condition would just go downhill completely. And there's some really good research coming out of Canada. I think it's by, I think his name's Matt Jordan, and he mainly works with Winter Olympian athletes. And part of his PhD was physically profiling people well after their ACL reconstruction and identifying that we do a really good job in this first 9 to 12 months. But then we go, hey, congratulations, ring the bell, I finished rehab. And then we forget about these people. And majority of people that re-rupture is in that first 12 to 24 months post-graduating rehab. It's not at the 9 month mark when they finish. And it's because we just forget about these people. So we need to be continually testing these people to monitor their physical condition well after the rehab process is done. And we need to be reiterating to them that once they've had this injury, they need to be working on their body for the rest of their time playing sport. It's not just during the rehab.
Yeah, amen to that, mate. Seriously, it needs to be said and needs to be heard, because you see it so often. They finish their rehab and they think they're all good. And you're like, you're not all good, mate. You need to keep going. You need to continue this rehab going forward. And even little things like getting sloppy with their pre-training warm-ups, your FIFA 11 plus, your footy, your netball stuff. then they just get slack on that. They turn up to training. They don't do that. And we know with the research that they help. They can reduce injury. They can reduce injury risk by up to 50% if they do them 2 to 3 times a week before training in games. We know that they help and they reduce the risk. And
it's like,
it's a
how
no-brainer.
simple.
Yeah.
How simple is the FIFA 11 plus?
I know.
It's a few hops, it's a few bridges, side planks, and you're right. It astronomically reduces the risk of injury. And this is where, again, like, this is just anecdotal, but the ones that don't do so well, it's you ask them the story and they go, "What?" And this is where our social sport is, like, whilst it's fantastic, I think this is like the rise in social sport is possibly linked to the rise in injury and re-injury, because this is where people just rock up 2 minutes before the sport. They've come from sitting at the desk all day and they run out onto the field. And again, there's so many other factors at play. There's all the synthetic surfaces we have these days. I'm not too up to date in terms of where we're at in terms of the different types of grasses. I know that was a big thing about 10 years ago, but they rock up, they get out of their car, they hop onto the field, and then bang, something happens, and they don't do anything before their game. So again, that's just purely anecdotal, but it's all these things, and we know that there's simple systems in place. And again, the better orthopedic surgeons, they'll give their patients the FIFA 11 plus, and they'll plead with them. They go, like, just do this. If you don't do anything else, just do this.
Exactly. Yeah, I completely agree. Like, if you're not going to do anything, you're not going to go to the gym and do any strength stuff, just do a decent reducing risk of injury warm-up. Like, that is king. And like, I've got the review boys in the AFL at the moment, every age group there doing it. And like, they look at me and they're like, really, we have to do this fucking thing again? And I'm like, yes, every single time. And it's to the point where they don't even need to look at the board I've written down. They just know it now. And I want that to become ingrained, that they don't even think about it. It's just bang, bang, bang. Every single time they get to training and games, they do the warm-up. But yeah, people just neglect it straight away. Like, I see it so many times. You know, you see them 6 months after they've gotten back to sport and they come back in, they might not have even ruptured their ACL again. They might just start to get some anterior knee pain or something like that. And you're like, have you been doing the FIFA 11 plus or your warm-up? No. Have you been doing your strength work? Oh, I chuck it in at the end of chest day sometimes. And you're like, my God, you've told them to continue to do it, but they think that they're okay. And, you know, people will inherently take the easy route. And once they've finished their rehab, they think that it's, you know, everything's all good when it's not.
Absolutely.
Yeah. Now, one more question before we finish up. This is a shorter question because I reckon we should probably do 2.0 because I think we've gone for 50 minutes and I don't feel like I've even touched the surface. One more thing as well, I just will say about, you already said it in terms of protocols. I really like a framework and a guide, e.g. like the Melbourne ACL Rehabilitation Guide. Yeah, it's not too bad, like the one that Mick Hughes spruiks. It's not too bad, but you look at it and like some of the testing stuff at 9 months, you do 22 single leg squats off a bench with your knee at 90 degrees and that classes as a pass. I'm like, well, I had Ellie Brushin, who's a code hopper from from AFL and soccer. And at her 2-month test, she got 60. And you're like, well, 22, come on. Like, that might be relevant for a 60-year-old. That might be relevant for someone that's, had a really low baseline of strength. But for an elite athlete or someone that's really strong, like 22 is just not high enough. So you need to have your systems in place to accommodate different people and different athletes, different strength levels, different sexes. So it's not just you hit 22, you're right to go, or you hit this amount, you're right to go. And you also need to make sure that you're testing side to side. A lot of people miss that. They're like, oh, this is better than last time that we tested on the right, but they're not comparing it to the left. And in an ideal world, I will say one more thing. In an ideal world, you would have pre-injury testing done to compare to, but often we don't have that. That is one other thing that I would do with a non-operative ACL. Even if they try and go non-operative and eventually they go down the surgical path, say 9 months down the track, if you've done non-operative testing, much like the ACL post-op testing, at least then you've got testing numbers before you jump into surgery that you can compare to after the surgery. I think that's really important as well. And I do test people when they have a non-operative ACL as well. I might do a 2 month, a 3 month, a 4 month, 6, 9, whatever it is, and then redo it as well. I think that's important as well. Agreed?
Yeah, absolutely. And I think like what you were saying before about with the, say, for example, the single leg squats and the 22 reps, and that comes from, so it comes from some really good literature. But I think where the literature falls down, and this is in terms of with the rehabilitation, the return to sport markers, the operative versus non-operative, is that for really good quality research, you need really large cohorts. And to get really large cohorts, you're really sort of watering down the groups that you're dealing with, because how often are you going to get 1,000 participants that are 17-year-old girls that play AFL, touch football, rugby union, and that may also be a cross-country runner? It's like they just don't exist. Like the more specific you get to your patient, the further and further away they are from the research. So I think what we've got to understand as clinicians is that we have to base everything that we do off the research and the scientific literature. Otherwise, that we're just pseudoscientists. But we've got to adapt the principles of the research to the person in front of us, and understand that just because a paper said that 22 single leg squats is a good biomarker for successful outcomes post ACL injury and ACL reconstruction in terms of 1 year and 3 years plus post injury, is that it doesn't mean that those specifics is going to apply 100% to our patient, because they may have a far greater capacity than that. And by letting them regress to that capacity, we're actually making them worse.
Exactly. You want to shoot for the stars, and you don't want to say, for instance, Brushy, like she can do 60. Am I just going to be like, no, just stay there, mate? You know, you're 2 months post-op, you're already going really well. I'm not going to say just stay there. That's just ridiculous. We're always chasing, and we're trying to get better and better. And that test in itself is kind of nearly irrelevant, because she'd be able to do 100 plus when I do the 3 month test. And then you would go to a different test, you know, a Bulgarian 5RM or something like that, back squat 3RM. There are other options. You don't have to just stick with what's in the literature. And then you have to have a battery test. And that's why I use such a complex, well, not a complex, but I use a huge amount of testing especially in the 9 month, because I want to make sure I'm covering all bases. This leads me into my last question. Let's just do this really quickly, because I want to let you go. And also I'm wary that people get bored after about 25 minutes these days. Last question, knee extensions. So knee extensions for a post-op ACL. I really, really hate the fact that people think that knee extensions are bad and you shouldn't do them. They're absolutely no-brainer to do throughout rehab, but you need to obviously wait the necessary time before you're doing, you know, full through range, like complete range. When do you start them? Why do you think they're so important? And what's typically a protocol early on?
Yeah, look, it's a really good question. I find that for me, I integrate them in reduced ranges of motion. So, I mean, we know that the peak shear amongst the ACL is in sort of that last 30 degrees of knee extension. So if you're in the shallower ranges, you're more or less okay. I typically integrated it as part of like an isometric
yeah, me too.
exercise for neural drive to the muscle reasonably early. However, it's not a huge focus of mine early on, mainly because with the processes that we go through with our athletes, we're working on a lot of patterning, and we're spending a lot of time on patterning. So whether it's a squat pattern, a hinge pattern, gait patterns, their early stage plyometric continuum drills, I find, and again, possibly we're a bit lucky, we've got, say, for example, the blood flow restriction cuffs from Chris Gaviglio's sports rehab tourniquet company with us. I find that I can generally, in most people, get enough of a quad stimulus through the closed chain format, because again, like the person's not going to be able to tolerate large loads under a knee extension early in the piece anyway. So I would then have to apply the cuffs, and they'd have to do sort of probably lots of repetition. So that's why I really like it as a isometric motor unit stimulus rather than a traditional sort of strength or muscular hypertrophy stimulus early. And then once they're able to get to the point where they can go through full range of motion with it, then it's honestly, it's integrated through the rest of the rehab stage, because we know that these people are going to compensate on bilateral lifts, particularly with the contralateral limb.
Exactly.
But I even see it in unilateral lifts where on a Bulgarian split squat, particularly when the ACL leg is the back leg, they will completely offload it and offload the front leg. On a single leg squat, they will possibly tend to hip dominate the pattern more and use their glutes more than their quads. So we need to find ways to really isolate the quads themselves, and the best way to do that is a knee extension. So for me, it's pretty much incorporated. Yeah, it might fly in and out of training blocks, because we've got to keep, again, going back to your principles of training. One of them is variety and reducing monotony of training. So we've got to make sure that we're giving it to the athlete at the right time. So that might mean it flies in for a block and you're working on some hypertrophy stimulus, and then it flies out, and then it flies back in, and we're maybe working on a little bit more max strength. So you change your set and rep schemes. You might put it a bit earlier in your sequencing. That comes down to the art of coaching and programming. But I think we're too many, as you said, and look, there's a lot of people sort of talk about these days. Too many clinicians shy away from it early on out of being fearful. And I guess we know, like, there's more literature coming out suggesting to us that it is quite safe, that there are similar shear forces going through other exercises such as squats and shallow lands and
even just
other
walking,
exercises like that.
the amount of Newton force going through your knee when you're walking is actually really high. And if you look at it compared to a knee extension, it's actually not that far off. And it's actually greater in certain degrees of knee flexion when you're walking. So I completely agree, mate. Like, isometrics to start with is a really good place to begin. And, once you're hitting that sort of 3-month mark, you can really load it up. And I also use it as a test as well going forward, knee extensions, single leg. You've talked about the dynamometer stuff before and isokinetics. It's important to test the single leg knee extension going forward, because we know that quad deficits is exactly what we don't want going forward. And it's a great way to isolate it. And I know myself, it's funny you mentioned that, when you're saying a Bulgarian or a squat, you can hide a little bit and not hit the quad as much. And I even know that myself with my left knee in the last 6 months. When I do a Bulgarian, I can hide my quad pretty easily by loading up a little bit more into that sort of hinge pattern and I feel it heaps more in my glute. So I've just tweaked things up a little bit. Now I'm feeling it so much more in the quad. And one of the reasons why that is because I do really good tendon prep before, but a lot of that is just that motor recruitment and neural drive early on. It's so important. And the way I get that is with a single leg knee extension.
Yeah, absolutely. And I think what we've also got to remember is that if, say, for example, you have an athlete that's got a bone patella bone graft, you absolutely do need to condition them to isolated work, or a quad tendon graft for that matter. You need to condition them for isolated work towards the quads. Otherwise, they're going to get negative changes towards where the harvest site came from, and they're going to be more exposed to pain and weakness ongoing, which will impact your ability to return them to sport. It's the exact same as if you were to say, like, I mean, yes, a little bit of a different context, because there's not any conjecture around hammy exercises, but it'd be like not loading a hammy graft and expecting a good outcome. You've got to put these people under load, and their programs almost have to look differently. And I think that as a profession, we haven't even scratched the surface in terms of individualizing programs in general, but changing programs depending on if they've got a patella tendon graft, hamstring graft, if they've got an extra articular tenodesis. Like, all these things affect the rehab, and we're not even at that stage of being able to have those discussions yet, because we're still fighting on these useless discussions.
Yes, exactly.
Extensions, yes or no?
Yeah, I completely agree, mate. It does my fucking head in. Seriously, I'm tearing my hair out when I see this shit, and when clients come in and tell me that they've heard this, and I'm like, oh my God, we're still here. But Another good analogy is if people want to get bigger biceps, if they just row and chin up, yeah, their biceps will probably get bigger, but they'll get a hell of a lot bigger if you did bicep curls on top of that. It's the same thing with the quad. Like you're gonna get bigger quads probably if you hit them with leg press, squat, Bulgarians, that sort of stuff. But as you said, you can hide, and the best isolation movement to make sure you're smacking the quad, especially, is single leg knee extensions or double leg.
We have a very one side or the other side mentality in this profession. Like it's either non-operative or operative. We can't, for God knows whatever reason, we can't combine the two. It's either knee extensions or no knee extensions. It's either return to sport testing or no return to sport testing. And the thing that I say to all of this is that perfect is the enemy of the good. If you're waiting for the absolute, like, perfect evidence to suggest one way is the best way, rather than just going, there's benefits of everything, let's combine them all and work together, then you're just going to be lost and you're never going to get anything done. And the only person that suffers is the patient in front of you.
Amen to that. And research is often a long way behind as well. They say sort of that 10 to 15 year mark. So if you're waiting your whole life to find this perfect research and perfect protocol and everything, you'll be dying a pretty unhappy person because you'll never find it.
Absolutely.
Yeah, mate, great chatting. I think we went for over an hour, but if people want to listen to it, they will, I suppose. Thanks again. It's been heaps of fun and love to do it again. I seriously reckon we've just scratched the surface there. Maybe it's worthwhile having another chat, maybe after I do the one with Musgrove and Rowe. And that would hopefully be probably in about a month's time. I think Justin was saying the 18th of June we'll do it. So that'd be great to chat after that.
Absolutely. And I think it's fantastic that you and Andy have recommenced that podcast. You've produced some fantastic content earlier on. I know a lot of people that were big fans of it and all the episodes that you guys did. Justin and Tim are fantastic. They're fantastic clinicians. They're fantastic speakers. So I can't wait for that episode to come out.
Yeah, I can't wait either, mate. And where can all the listeners find you? Instagram, website, all that jazz?
Well, yeah, I don't personally have a website, but if they wanted to, they can find me on the Athletes Authority website. So that's just www.athletesauthority.com.au. I'm mainly on Instagram, which is just @jrehab_. And then I'm also starting to pick up my LinkedIn content. So that's just my name, Justin Richardson. Otherwise, if anybody does have any questions, they want to get in contact with me, probably best to just shoot me a message over Instagram. I'm more than happy to answer. And if anybody wants to come and check out the facility at AA, if they're Sydney based, more than happy to show them around.
Yeah, and I think the other thing, new grads and even physio students, if you ever want to, hang out with Justin or I while we're rehabbing a client, especially an ACL client, I feel like both of us would be absolutely fine with someone shadowing us while we do it. Even if you wanted to check out what we do in terms of the testing, more than happy to help. Him and I have been doing it a long time, so it's taken years to perfect, and it's only going to get better and better from here, and you're always learning. So yeah, feel free to reach out at any point. This podcast is live on Apple Podcasts, Spotify, and Google Podcasts. Any last words, Justin?
Not at all, mate. Honestly, if people are still listening to us come this point in time, then they deserve me to buy them a coffee.
Yeah, exactly. A full hour. That's impressive, guys. But yeah, thanks again. We'll do it again soon. And as usual, stay strong, guys.